Hello and welcome to our IMVi Journal Club for the month of May. My name is Kirstin and I am one of the in-house vets for IMVi Imaging. This month we are going to discuss percutaneous ultrasound-guided cholecystocentesis, otherwise known as PUC, with a focus on complications of this technique as well as looking at how ultrasound findings in dogs and cats relate to bile culture results. So here's the title of the journal article I'll be focusing on today. And it was written by Shabora, McConnell, and Maddox from the Small Animal Teaching Hospital at the University of Liverpool. And it was published in 2017 in the Journal of Small Animal Practice. It was a retrospective, or it is a retrospective cohort study focusing on a population of 300 percutaneous ultrasound-guided cholecystocentesis procedures presented to the University of Liverpool Teaching Hospital between 2009 and 2016. And these procedures involved 201 dogs and 51 cats. And the discrepancy between these two numbers of 300 and 252 is that many of these patients were presented twice, 3 times, or 4 times, and even 5 times in one cat for the same procedure. So I think it was twice in 26 patients, 3 times in 6 dogs, 4 times in 2 dogs, and 5 times in 1 cat. So why is this paper of importance and interest to us in small animal practice? Well, ultrasound assessment of the hepatobiliary tree is commonly indicated, and bacterial cholangitis is a relatively common cause of hepatobiliary disease in cats and dogs. Structural changes in the gallbladder have been associated with bacterial cholecystitis. However, their sensitivity and specificity for a positive gallbladder culture has not yet been defined. Some of these structural changes include wall thickening, a dilated common bile duct, double-layered wall appearance, a hyperechoic wall, hyperechoic content, and cholelithiasis. PUC is minimally invasive, inexpensive, and can be performed on an outpatient basis. At the moment, there have been conflicting reports of complication rates in the use of PUC in small animal practice. But many of these studies had a very small sample size. There is question over whether this technique is perhaps underutilized, and I think it's safe to say that PUC is not a commonly utilized sampling technique outside of specialist practices because of the concern of recognized complications such as bile peritonitis, bile leakage, hemorrhage, sepsis, and vasovagal reactions. Our study aims were defined as: what is the incidence of major complications in cases presented for PUC? Are there any risk factors for complications? And how do ultrasound findings relate to bacterial culture results? Let's discuss materials and methods. The study included patients presented to the University of Liverpool Small Animal Teaching Hospital between 2009 and 2016 for PUC procedures. All the case records were reviewed on certain criteria that included signalment history, number of PUC procedures performed on different occasions, immunosuppressant treatment, the presence of a bile culture results, cytology results, and ultrasound findings. It must be stated that the inclusion and exclusion criteria was not well defined, and a few potential problems spring to mind here. It's not stated what time span could have elapsed between the ultrasound exam and cholecystocentesis. So there was no maximum time span defined here. There was also no detail specified on what type of culture was performed. For example, was it aerobic or anaerobic, or if this process was standardized or went through the same lab. The authors describe looking at the use of immunosuppressant therapy in the cases as part of their criteria for review, but they don't detail how this was used in the study or if it contributed to this patient being excluded or included in the study. 35 patients had PUC performed twice or more. And there's no detail provided on what kind of gap occurred between these procedures. So one thinks, should these repeat PUC bile culture results have been included after the first visit, as they may have been placed on antibiotics? There was also no information on prior or current antibiotic therapy that these patients may have been receiving and that may have affected culture. And there's no information on previous hepatobiliary disease that may have confounded ultrasound findings. The historical ultrasound exams were performed by a radiologist, radiology resident, or an experienced ultrasonographer. And then these exams were reviewed retrospectively by the first author, who I understand was a radiology resident at the time, for certain ultrasound parameters, which we will detail in a further slide. There was no blinding specified for this author in terms of bile culture results or case history when reviewing these ultrasound exams. And only one reviewer is detailed. Ultrasound findings were then defined as abnormal or normal. And self-limiting or minor complications were not included in the study, as they were not consistently recorded, and the authors feels that it did not affect the final outcome. So complications were defined as a major adverse effect, i.e. clinical deterioration or death, within 3 days of PUC. So I found that the paper title and abstract is a little bit misleading, as it consistently refers to simply the complication rate rather than the major complication rate. And subsequently, appropriate statistical analysis was undertaken. Here we'll look at the ultrasound parameters that the author assessed on the historical ultrasound images. And I think recognizing the ultrasound parameters defined for gallbladder pathology are an interesting takeaway for readers that are still developing their clinical ultrasound skills. So these parameters included mean thickness of the gallbladder wall, measured in 3 locations, excluding the gallbladder neck. And a normal mean wall thickness of the gallbladder was defined as less than 2 millimeters in a dog or less than 1 millimeter in a cat. They looked at maximum wall thickness, irregularity of wall thickness, presence of a double wall pattern, presence of irregular luminal surface, a diffusely hyperechoic wall, and the pattern of gallbladder contents. Was it normal, echoic, did it have an anechoic rim, anechoic fragments in an echoic sediment? Was there a stellate pattern, a kiwi fruit pattern? Was there the presence of hyperechoic sediment, a cololith, or was the gallbladder empty? Let's look at some images and videos of this type of gallbladder pathology. On this video on the left, we have a really nice example of a double-walled gallbladder, or a halo effect in the gallbladder. We also have a thickened gallbladder wall, and within the lumen of the gallbladder there is the beginning of, I would say, a stellate pattern with echogenic sediment stretching from one side of the gallbladder to the other. And this would be consistent with an early mucocele. On the right, we have a gallbladder with echogenic speckles within the lumen, consistent with small amounts of floating sediment. The gallbladder wall appears hyperechoic, and we can also see that the common bile duct is very dilated in this patient, severely dilated in this patient. The image on the right, top right, was taken from this paper and was used to illustrate what an irregular luminal surface looks like. We can actually see little polyps extending into the gallbladder lumen. And the wall of the gallbladder is actually irregularly thickened. So in this area, we have a much thicker wall than in this area closer to the probe. On the bottom left, we have an example of sediment that is causing an acoustic shadow, so it's likely to have more of mineralized content in the sediment. And important to know that not all sediment will shadow in this way. And on our bottom right here, we have a classical kiwi fruit pattern of a gallbladder mucocele. Moving on to results. In terms of complications, the overall incidence of major complications was found to be 8 out of 300 PUC procedures, which was 2.7%. These 8 complications included 5 dogs and 3 cats. Interestingly, only 2 of the complications involved a condition with a very clear direct correlation to the procedure, i.e. bile peritonitis. The other 6 developed major complications such as SIRS, hypertensive shock, acute kidney injury, cardiorespiratory arrest during anesthesia, which, although an association with PUC cannot be excluded, there's no direct evidence for this and other procedures that were undertaken on these patients, such as hepatic biopsies, and the patient's concurrent disease having had been responsible for this patient's complications. With regards to bile culture and cytology, 64 out of 294 culture samples tested positive, which is 26.3%, with mostly enteric bacteria, E. coli, enterococcus being the main ones that were most often isolated. And this does agree with previous studies. 1 out of 6 dogs with mucoceles had positive bile culture, and they did also put their results of bile cytology. 35 showed lactobacillia, 25 increased mucus content, 7 inflammatory cells, and 134 no significant findings. So nothing too interesting coming forth from the bile cytology. Obviously, the presence of positive culture results in dogs and cats here would be higher than an average population, I suspect, as obviously there's some selection bias. There would have been a strong clinical suspicion that prompted the decision to sample and culture bile in the first place. However, I don't think this is a major weakness, because in a similar decision-making process would be followed in any practice environment. There's no point in sampling a patient in which there's no clinical indication to do so. It must be noted here that samples were pooled between dogs and cats, so there may be species differences between the relevance of bacteria in bile, and in fact, there is some authors have suggested that bacteremia is less significant in a dog versus a cat. So this might have created this has sort of negated any species differences that might have been important to note. Ultrasound finding results. 294 out of 300 PUCs performed had adequate ultrasound images, and bile culture and ultrasound images were available in 289 cases. 50 out of 289 had abnormal ultrasound and positive bile culture. 11 out of 289 had normal ultrasound and positive bile culture. 101 out of 289 had abnormal ultrasound and negative culture. So there was a sensitivity of 82, specificity of 55.7, and accuracy of 61.5%, which is fair to middling. Important to note that both species were pooled here, so pooling the species in this way could miss important differences in the sensitivity and specificity that may be species specific. Other associations that were made were highlighting that maximum gallbladder wall thickness and irregular luminal surface from the array of all the ultrasound parameters looked at were significantly associated with positive culture on a multivariable analysis. Let's discuss the shortcomings of this paper. This was a retrospective study, like most in veterinary science, with many forms of selection bias present. No blinding attempts were specified. It was not clear if the author was blinded to case details when reviewing ultrasound images. The inclusion and exclusion criteria were poorly defined, and I did cover most of these concerns in the materials and methods slide. But just to highlight a few important points. The history of antibiotic use was not included. I found this a significant omission on the part of the authors, as these patients may have only been culture negative because they were currently receiving or had received antibiosis. The fact that this was a referral hospital may have increased the significance or the chance that these patients had already received antibiosis before being referred. There was no history included of previous episodes of hepatobiliary disease, which could confound the appearance of the gallbladder ultrasonographically. The culture process was not defined. Whether a sample submitted for aerobic or anaerobic or both, was the same lab used? Was there a standard technique followed at the lab? There was also no process clarified on how representations for PUC were handled, which may have had a significant impact on the relationship between the ultrasound finding and the bile culture results. For example, if the PUC was part of the same disease process and antibiosis had already been instituted. Gallbladder pathology reviews were very dependent on the original operator of the ultrasound. For example, the original operator may or may not have saved enough images to represent all the pathology present in the gallbladder, for example, and it was not clear if there was a formal report generated for the initial ultrasound. The results in this study were pooled for species, which may have meant there were important species differences that were missed. The PUC technique used was not defined in the study. I can understand this may not have been detailed in the case history, but it would have been useful to ascertain whether different techniques were used and if there was differences in risk for different techniques. There were no post-mortems undertaken on the patients that suffered major complications to confirm the clinical suspected diagnosis. "9.7% of the patients that presented with PUC were lost to follow-up after 24 hours, or were not followed up after 24 hours. The authors did state it was unlikely that patients with major complications neither represented at hospital or were notified by owners or the referring vet. However, it remains possible that major complications were overlooked in a subset." So what are our conclusions and takeaways from this paper? I think it's safe to say that the shortcomings in the study design would have had more of an effect on the study aim of relating ultrasound findings to culture rather than ascertaining what the major complication rate was of PUC. And it's a credit to the authors and the paper that the study size of 300 is very good for a veterinary study. The firmest and most valuable takeaway we have from this paper is that PUC appears to be a reasonably safe procedure with a low incidence of major complications in appropriately selected patients. By that we mean not performing PUC in patients where PUC is contraindicated, for example, cases with emphysematous cholecystitis or patients with coagulopathies. Secondary conclusions that may be drawn from the paper but must be interpreted in light of the shortcomings include that the sensitivity, specificity, and accuracy of abnormal ultrasound findings to predict positive culture was only fair. And a thickened gallbladder wall and irregular luminal surface have a stronger association with positive culture results than other indicators of ultrasound pathology on ultrasound. 2 out of 6 patients with mucoceles developed major complications, and only one out of 6 of these had a positive culture. So the risk may outweigh the benefit to sampling mucoceles. This may be due to the fact that mucoceles are associated with necrosis of the gallbladder wall, which would make leakage and rupture more likely. Lastly, the paper was unable to indicate that there was any predictable relationship between the severity of gallbladder findings and a positive culture result. Before we end off today, I'd just like to expose you to this paper published in JVIM in 2017, which was very similar to the article that I have just reviewed, but it assessed cats and dogs separately, and it had some very interesting results. So it's out of scope for today, but if this paper did interest you, it's really worth a read. So here it is, association between gallbladder ultrasound findings and bacterial culture of bile in 70 cats and 202 dogs in JVIM 2017. Thank you very much for listening. You can please submit any questions you have via the question box, and then a reminder to keep an eye out for the live Q&A session, which will follow this screening. Our Q&A sessions allow for collaborative discussion between our clinical team and yourselves as listeners around this article, and any questions that might have been submitted today. Thank you.